Santana-Chin is the Medi-Cal President for HealthNet. Ybarra, President of California Medicaid for Anthem. And Kristen Cerf is the CEO at BlueShield California Promise Health Plan. So I'm really looking forward to this. Kelly, we're going to start with you. And in the course of your remarks, you also have some videos. So
thank you so
take
much.
it away.
How's my mic? Can you
You're
hear
good.
me?
Yeah.
Great. Hello, everyone. It's so great to be here. Thank you for inviting community-based organizations to be part of the conversation today. I'm really pleased to be here representing all of us across the state and the great work ahead. Sacramento Covered, we're obviously a local organization working where we are a long history, 24 years in Sacramento, really steeped in healthcare navigation for low-income folks. And we connect people to care, help them use that care, and mitigate any barriers. And the backbone of our work is really community health workers. I was so pleased to hear the question right at the top of the day about that we were going to be talking about community health workers and really the richness that they bring to this work, because they really are the embodiment of Calaim. But rather than droning on about my perspective, I'd like to share a little piece that gives you a glimpse of the day-to-day for our community health workforce.
Let me tell you about Sacramento Covered with one word: hustle.
We are a compassionate team of community health workers
determined to succeed.
We succeed when our clients achieve their health and well-being goals.
Our field-based team works alongside people with the greatest needs to coordinate robust health and social supports.
We meet people where they are and put their values and needs at the center of our approach.
Whether it's providing support to people in shelters, in their homes, their neighborhood, at a local hospital,
Or working closely with health plans, housing agencies, and local government.
Our team works together to make sure people get the best possible care that reflects their needs.
We walk, run, stand beside, lend an ear or shoulder.
we hustle and advocate for our clients as they navigate all of the systems of care that unfortunately are far too complicated.
We stand with them on what can be a challenging road to stability and wellness.
Sacramento Covered, where your health is our mission.
Yeah, nice.
Thank you. So fast forwarding to today, as I mentioned, we were born out of deep health navigation work. And nearly 5 years ago, we found ourselves in a pretty pivotal role for whole person care, implementing whole person care in Sacramento. And what was unique about the Sacramento pilot is that it was led by the city. So we, instead of our county, like every other county across the state. So that really put us in a unique, multifaceted role for whole person care. And so we're coming off of the learnings of that. Our community health workers carried the caseload of the whole person care enrollees. We did the data management functionality, the eligibility enrollment functions, and then we also lifted up care coordination and housing support services with many other partners in Sacramento. I'd be remiss not to mention all of our FQHC clinic partners, other housing agencies, and the city of Sacramento, as well as the county. Today, that means we're in a very unique place to be a community-based agency now contracted with all 5 managed care plans in the county of Sacramento, and that includes Anthem, Aetna, HealthNet, Molina, and Kaiser. Did I get them all? Good. And in particular with Kaiser, we're actually expanding beyond Sacramento County and serving a 7-county territory. So I say that just to give you a glimpse of what it means for a community-based organization to be part of this work. We served close to 3,600 clients in whole person care and health homes. We also worked in the health home space since summer of 2019. And it's really, as an organization, really changed us, our DNA. But it was so close to home to lift up a community health worker team to do this work. And that's really what, I'm completely biased, but CHWs are really, again, the backbone of meeting people where they are, breaking down silos, knocking on every door possible to make sure that the most vulnerable clients and patients that we serve have access to the services they need to improve their health. And with that, we wanted to give you let you hear from them directly. So we have a second part of our little video here. Please enjoy.
I can recall one client who he was sleeping outside of a shelter because he couldn't navigate his way in because he was blind. And he couldn't go across the street to get any food services, both because he was blind and deaf, and he was afraid of 18-wheelers coming and hitting him. I was able to get him into a shelter, get him Social Security so he had monthly income, CalFresh so that he had food stamps and ability to feed himself. We actually got him a hearing aid so that he could start hearing. And I got him connected into a permanent supportive housing program where he had housing for the rest of his life at very low cost to him. And once he was inside and out of the elements, then they were able to schedule surgery, and he regained sight in one of his eyes. And I got a call about 2 years later from him. There was a fire at the apartment complex that he was living at. He was able to get up and knock on everyone's door and save 15 people's lives. And he called me to thank me for saving his life so that he could save others' lives.
Those type of instances of us helping people like that, or what makes this job the best?
It's hard not to get emotional with this job because you do get so involved with these clients and you want the best for them. It makes all those hard days and challenges worth it.
That feeling, like even now, goosebumps, chills.
We all have the same common goal in mind, to help people experiencing homelessness in Sacramento County.
That was just a part of what we do. Just because you get housed, that don't mean we stop from there.
It makes all the hard days worth it.
That's what the world's about.
I feel grateful that I've been able to be in someone's life and help them. That's what matters most to me.
Thank you so much for, we're pretty darn proud of our team at Sacramento Covered, as you can tell, and we finally have a video to share with the world about the great work. So in the Calaim implementation, just to give you a sense of, we've obviously transitioned population from whole person care and health homes into Calaim programs, ECM, and community supports. We're contracted with all 5 plans, as I mentioned, for both ECM and community supports, and we have a current caseload of just over 1,200 patients. And the work is truly field-based. It is in touch and in person and assertive, and it literally is knocking down and beating down doors on behalf of the clients that we serve that have really the highest need among the Medi-Cal population. So with that, I'll close and
That is just great. I have to admit, yesterday when I watched that video the first time, I had tears in my eyes. And I do again. It is so moving and it's so great, and it really underscores the importance of the entire objective of what Calaim is all about, which the health plans are, have to go about implementing. So, Martha, let's start with you. Yeah?
So, is my mic okay? Yeah. All right. So, HealthNet is, it's a California-based company. We were founded actually 40 years ago, and in California, and have been partnering with the state to serve Medi-Cal members really since Medi-Cal was an option in terms of managed care support. And, you know, over those decades that we've been working with the state, we've really worked hand in hand with them to develop programs to transform the program for the better of our members over time. You know, at the plan, we have many individuals that work for us that have members that are living in our communities that have lived experiences and or supported individuals in different ways. And we're really excited about where we are right now, because it's for the first time in many of our careers are we really at a place where we have an opportunity to collectively organize around the needs of the members more holistically with partners like, you know, Sacramento Covered. And the nice thing about all of it is that the state has moved with very aggressive and bold moves, making some of these things benefits, right? For many of the organizations that we worked with for many years, they've been grant funded for some of these services, and they live, you know, grant by grant. And so we are in a unique position now to really serve the needs of the members that we serve more holistically and systematizing things, which is really very exciting. HealthNet has 3 million members in the state. 2/3 of our members are in Medi-Cal, to give you a sense of depth there. And we've had the privilege to serve 11 counties that are also health, homes, and whole person care pilots. And through that experience, we had a lot of learnings from those programs that we now transitioned into the Calaim space. But even with that, I got to tell you, we're approaching this with a lot of humility, because there's a lot of learning that the plans still have. You know, we're learning every day from the continuums of care, from, you know, community-based organizations, from, you know, providers that have been serving very complicated needs holistically. And so what we have really centered around and understand is that in order for us to do a good job of serving this population, in particular those with complex needs, both social, physical, behavioral, the care has to be local, right? So, you know, Kelly talked about, you know, in-person, high touch. Absolutely, that's right. And so for us, it's about working with the behavioral health providers that are in the community. It's with working with housing agencies, community-based organizations, federally qualified healthcare centers. We've got partners up and down the state that have been serving these individuals for decades, and now it's really just about us supporting them with a different kind of infrastructure. What we've learned also is that we have to be very agile, right? And I'll give you a couple of very specific examples. We have organizations that are now contracted with us that really have only worked with invoicing processes. So when you think about all of the requirements that are put on the plan to capture things like encounter data, it's foreign concepts to many of the organizations that we're working with now. And so we've had to build infrastructure to support those organizations, to meet them where they are, by taking paper invoices, translating them into encounters, all the way to organizations that have a different level of capability are actually able to transact with us electronically. We've also learned a lot in terms of what's necessary from a workforce development perspective. And we're not there yet, but we know we have a role to play in really supporting and enabling communities on that front. And, you know, we're trying to be as flexible and as agile as our provider partners have been. One of the things that has also been, I think, a bit of a silver lining is that the last couple of years have had a different level of demand on all of us. And as a result of that, in some spirit, for the sake of survival, we've all collaborated at a different and unprecedented level. So, many of my team members here, right, we're at the table together trying to figure out how to implement this program and collaborate so that we make things easier for the communities that we serve. So that collaboration has been foundational to really taking this to the next level. And just a couple of examples I'll share with you in terms of collaboration, not only with health plans, among and between plans, but also with county agencies, with CBOs, with some of the same organizations that I referenced earlier. We've really been able to streamline processes. So, we developed joint application processes for the provider community so that we all accepted a single application as opposed to every plan doing their own thing. We are identifying ways to support data exchange capabilities in new and innovative ways, again, to meet providers where they are. We've also, focused very heavily on integrating physical, behavioral, and social services. We're by no means there, but the discussions are happening. We have folks from the substance use disorder programs, behavioral health programs, physical health, social services, all informing our programming. And so we're very optimistic about where this is going to head. And believe that we really have the ability to deliver on the promise of Calaim. One of the things that has also been instrumental and fundamental is trust, right? A number of parties at the table historically didn't have the strongest of relationships, and I would even imagine in some cases, the partners didn't necessarily trust the system. And now, because there's active listening, leaning in, learning, there's a willingness to allow for the trust to develop, which is, I think, really critically important. When we launched Calaim, HealthNet, as an example, has 13,000 members that are now on enhanced care management programs and about 8,000 that are receiving community supports. When we transitioned from whole person care to health homes to Calaim, it wasn't perfect. We had hiccups, there was problems. But what happened in that process is that trust that I talked about earlier was very apparent because we had very honest conversations and got at the heart of what the problems were to work, collectively and in partnership with the state, the plans, and the providers to address the issues that were bubbling up. And, I'm sure there's going to be more, but, we're working through it. And then just, lastly, we have also opportunities to build for the future right there. So there's incentive programs out there that providers, plans, counties can earn. And so that collaborative spirit that we've already developed is going to really be critical as we think about how to braid that incentive funding very strategically in the future and for the future. So very excited about the promise of the program. A lot of work still to do, right? It's not by any means done. But we know we're going to get there.
Yeah, thank you, Martha. Les?
Great, thank you. So good afternoon, everybody. My name is Ybarra. I'm Plan President for the Anthem Medi-Cal Health Plan, and just really pleased to be here with you all this afternoon to talk about Calaim and really reflect on, I think, where we've been and then presently where we are and where we're headed. And when I look back a little bit, especially from this morning when Director Bass spoke with us about the state's vision and strategy and ultimately a transformation of the Medi-Cal Managed Care Program. So it really is an honor to be here and be at the table for that effort and really be part of the transformation. And really, I think at the health plan level, there's a lot of responsibility being placed upon us really to implement these programs and to make sure that not just from a policy perspective, but actually make things operational, which can tend to be the hardest thing. When we think about the capacity building that's occurring presently, we're going through assessments at a local level. We're rolling up the sleeves with our stakeholders to really identify where are the opportunities, where are the resources, where can the health plan fit in that, but really kind of orchestrate the services that need to be rendered. And when I think about the populations that we're serving, in some ways we've been doing this work for many years. We're now actually have an opportunity for state funding to come through to push these programs formally. And I think about my history at Anthem. We started in 1994 here in Sacramento County, the inception of the geographic managed care model. And we were part of the beginnings of the two-plan model as well. And I started shortly after that at Anthem back in 1999. I was actually an uninsured Californian at the time when I interviewed for my first job there in operations. So really an honor to be in a plan president role at this time. But when I think about some of the care coordination that I directly was involved in back in the early 2000s, I kind of reflect on what the program is asking of us to do today. And in some ways, it's not that different. When we think about the members that would call and they needed assistance, I directly assisted somebody with the victim of domestic violence. She was injured significantly. We had to have surgeries in Los Angeles. And I remember being involved in sending one of our leaders to rent a hotel room so that she could be there in advance of the surgery. So Central California member, we paid for the transportation at a time when transportation was not a benefit. And we actually had somebody use their business card to pay for the hotel room and then transport her back from Los Angeles to Central California. And when I think about that, some of these things, they're all benefits today. But in the early 2000s, in those years, that wasn't part of the program. These were things that we were doing since then. And so when I think about, what's ahead of us, we've been at the table for a couple of years now, as Martha stated, with regards to the pilots, whole person care, health homes. Anthem has been involved in 10 counties across our current 29 county footprint. We serve 1.4 million members across California, but currently in Calaim, when we went live in January, this is just the beginning, right? This is phase one. We're faced with a 5-year rollout. So as much as we'd all like to claim victory for what we did in January, I think we sit here very humbly knowing that it's only the beginning of what we have to get done. And this is only part of the transformation that Director Bass was speaking of with Department of Healthcare Services and all of the strategies that they're deploying. Those strategies are really requiring us to think about how do we implement at a local level, how do we work with our community-based organization partners, and great example of the video with Sacramento Covered. We think about how to reach people and doing that in a way that's culturally appropriate and competent, and really thinking about from a linguistic perspective, meeting people where they are, but also those cultural aspects of what we need to do. We need partners. Those relationships are really the foundation of us being successful in the programs. We have a lot of focus on measuring quality, and when we think about our most vulnerable, health equity is on top of our list, really identifying where the disparities are and putting those action plans in place to address them. And so with regards to the capacity investments, this first quarter of the year, going through those big assessments at the local level and finding where are the best places to utilize and leverage capacity building investments, making sure that in some cases data infrastructure is developed with our community partners, or making sure that from a plan perspective that we have reimbursement methodologies for them. And to Martha's point about invoicing, we joke about this often. We are at the very basic level of how do you bill for some of these social services. Hospital care, physician billing, we've been doing this for years. And we get involved in the community organizations that really haven't had to bill a health plan before. And from a health plan perspective, yes, we are very automated. We have lots of resources in the IT front. We have a ton of automation with our provider partners, but we're going back to the basics and really building from the ground up as it relates to some of the social determinants work that we're doing. And those reimbursement methodologies are critical to the survival of the program. Make sure that those state dollars come down through the plans and into the community. And so when I think about all the policy work that we've done in the past, so not only were we involved in pilots for the last couple of years, but we've been getting an awful lot of input. So I think the three of us spend a lot of time together in front of Director Bass and her staff, and making sure that we're giving the local health plan perspectives on how things can be operationalized, and ensuring that at least there's a voice and there's a collective effort. And so when we talk about collaboration, it's very important at all levels, from a policy level, from a plan level, and then at the local level. And even just at Anthem, we've been, really it's about 75 to 100 meetings per month in the counties that we're in, with health plans, with the county health departments, with community organizations, lots of information sharing, trainings. But we're also learning, so a big part of that is for us to listen and to hear from directly from the community about what those local assessments are yielding and where our areas of focus need to be. We know in California that one size does not fit all. It depends on, the geographies that we serve. When we think about, some of the larger cities, places where, we might have a different set of resources than a rural community, a very, very different picture across the state. And so we have, really the privilege to kind of think through those local needs and make sure that we're responsibly administering the program and we're really caring for the communities. When I think about reducing health disparities in California, and I don't think there's any other place on the planet that has a bigger challenge than we do. With the size of our population, some of the disparities that we see, and the responsibilities that we have as health plans continue to grow as the state really promotes its vision and looks to innovate across the country. At Anthem, we've been building infrastructure around health equity at a national level, but I get the privilege of actually administering much of that first across our company in California because of all the work that we're doing, starting with Calaim and everything else coming our way. So again, when I think about the past, I know we have a wealth of experience that we're bringing over the years. 28 years in Medi-Cal managed care. Me personally, 22 years. Been at the plan, kind of starting as an uninsured Californian, and now I do have great coverage. But when I think about the responsibility that we have, it's very humbling to address all of the needs. They continue to grow. We were just talking about COVID and the behavioral health needs, especially with our children and the student behavioral health program that's also in front of us. We have a lot of work ahead from connectivity, making sure we're connecting resources, reducing complexity, and it requires that all of us really kind of break down the barriers. We need to learn from one another. We need to at least build a roadmap of where can we get resources so each and every one of us can connect our children and connect our low-income Medi-Cal beneficiaries to care in every way possible. So again, really appreciate the opportunity to sit with you all and chat during your lunch.
Thanks, Les. Kristen?
All right.
Yeah, what can you add?
Ooh, it's going to be hard because we have quite the panel here. So Kristen Cerf, President and CEO of BlueShield of California Promise Health Plan. And we're in Los Angeles with our plan partner, LA Care, and in San Diego. And I think that the thing that I'd like to add that we have all sort of alluded to is that Calaim is hard, right? So let's just everybody give ourselves a round of applause because we're doing the work, right? And so I come from a mission-based organization, right, nonprofit, with a goal of ensuring that every Californian has access to high-quality health care that's worthy of their family and friends and is sustainably affordable. And it's deeply, intensely personal for me, especially when we get into the Medi-Cal space, where we're talking about the most under-resourced population. And we're talking about bringing in equity. We're talking about enhancing the care management and the services that they have. And we're in the process of building something that I think is tremendously important, right, when we talk about the overall health and well-being of every single person in the state of California. And I think Director Bass this morning really acknowledged we have a ways to go, and we're just at the beginning. And we also have the difficult work of a huge vision and a lot of tactical pieces that have to fall into place now and over the next 3 to 4 years for us to be collectively successful. And so I think of things that Martha shared and Les and Kelly. We're bringing in folks and providers that have never participated in the managed care system before. Right? They have to learn how to bill. We have to learn and participate and listen and collaborate and bring them along. And they're so critical because there are things like our sobering centers that our members need access to, housing services, meal services, things that every single person wants to make sure, right, that every person that you know and love has access to all of those things. And it's tremendously aspirational, right? So when I think of that, I also think of the fact that we're doing this during COVID and we're tired. And I'm going to say it again, this is hard work, right? This is the work of taking a vision and making it an operational reality. And also at a time when I think many of us know this, I think we've all been doing this at least 20 years, Our regulator is not necessarily at the forefront of giving us the information that we need, right? So we may not have definitive information and instructions on how we're supposed to implement certain things, and we have to do it anyway. And that's where I think that the unprecedented collaboration that the health plans have had between each other during the pandemic has become so important. And I would pretty much offer that that unprecedented connectivity is just the beginning of the level of connectivity that we need to have in order to successfully achieve the vision of Calaim. And I did hear Director Bass say this morning that it is healthier, happier, which I think is tremendously aspirational, people and communities. So I'll just offer lots of learnings, lots of opportunities here. I really appreciate the vulnerability and humility that we've all come to this with. I think that the other challenge that we have is how we are truly going to harness all of the data that we need to make this vision a reality, right? So we're supposed to be moving, and I think we all very much want to move into a more predictive model. So I always think, Amazon knows what I want to buy before I log in to buy it, right? They know. It's just the way the world works these days, and healthcare isn't there yet. And so our challenge is taking the data, taking these relationships, integrating with the communities that we serve, building those critical relationships with our community-based organizations and providers to gather the data to become like Amazon. So we know for our members, maybe you're going to need a meal service before you know it. You could be at risk for diabetes before you know it. And so it's really about that, and that I think is tremendously aspirational and also so critical for all of us to live, I think, the healthiest possible lives that we can. I'm very proud of the fact that we're already offering 10 community supports in San Diego today, 9 in Los Angeles, and we have an ambitious plan to get it all up and running by the 1st of next year. And as I look through, and there's so much within Calaim, the community supports are the critical underpinning to help us level those social determinants and to making sure that our members have the opportunity to have their best possible health outcome. So I will leave you with that and a word of excitement that it's very rare in your career that you have the opportunity to participate in a build. And every single one of us has a role to play and an opportunity to weigh in on what Calaim ultimately looks like and what it really delivers. So I'm going to encourage all of us to continue the collaboration. It is absolutely critical, and hope that we can build on it and actually bring more to the table.
Oh, that is a great. I appreciate your focus on aspirational and how we're trying to. I mean, I was told, your reach should always exceed your grasp, and it sounds like some of these plans in Calaim they're something that we're going to try to reach, but how are we going to get there? And I'm thinking, in particular, Director Abbas talked about affordable, accessible, high-quality healthcare, and there's a new word in there, integrated. Yeah. And so now we're talking about integrating not just the medical side, but the behavioral health side and the non-medical side as well. You all have laid out a great vision here, and the videos were fantastic in laying out the vision and the promise of Calaim. Are there any problems here?
Nope.
So, I'll bite on that one. I would say there's no shortage of opportunity. Lots of opportunities.
Yeah.
I reflect on a conversation I had just yesterday with one of our enhanced care management entities. And the physician who's in charge of that program, you could see the passion in her eyes. Like, she got into the business of caring for low-income individuals because she wants to make a difference. Mm-hmm. She wants to make an impact. And she was walking me through what she has to do in her own operations to really help us all achieve those aspirational goals. And she was walking me through how they're using the Prepare social risk assessment tool, right? And they're trying to figure out how do they translate that into the ICD-10 codes that we're going to need to be able to report upstream to evidence need and to connect need with support. Mm-hmm. opportunity number one. Second opportunity. She talked about closed loop referrals. Okay, that's I think if I had a nickel for every time somebody said that in the last month, I'd probably, I will take a vacation sometime soon, right? But closed loop referrals to the health plans and the way that it's written in policy is different than what that provider is experiencing. Her biggest concern and the opportunity that she saw was, how can the health plans help me vet community-based organizations out there that I refer my patients to and make sure that it's not an empty promise, okay? Because what happened historically is you hear a lot about organizations that are out there providing food supports, providing meals, providing domestic violence shelter, providing, right? But what happens is that on the ground, individuals, providers, community health workers are referring people, but they end up at the other side with nothing really there, right? And it's unfortunate. But those two opportunities as an example, if we lean in and try to figure out how do we help that provider in their workflows through their EMRs translate, right, to an ICD-10 code that then gets transmitted to the health plan, that's part of the way to achieving that aspirational goal. How do we make sure we have the systems and infrastructures to really facilitate that closed loop referral, not as we define it as a health plan, but as that individual member, as that patient, as that client and provider see it, so that when they do refer, there's something there on the other side. And it's not just community support services that the health plans are going to be providing, it's everything else around that individual's need, because I think, let's face it, the community support services are a really, really good foundational start, but there's much more that individuals need to get their needs met holistically. And so it's really breaking down those opportunities one at a time, right? With active listening and translating it into action plans. I mean, I don't know that there are shortcuts to any of this. We will get to the Amazon days, I'm convinced, but there's a lot of heavy lifting between now and then.
Yeah, Les or Kristen?
Yeah, I think about population health is kind of an interesting angle when we're expecting by early next year to have access to data that's very comprehensive across agencies. And so we're expecting this from a health plan perspective to be able to tap into and then feed our own population health data engines. And I think if this really does, if that strategy is really implemented the way it's being discussed at a state level and then on through the plans, we can really do enhanced care management the way it needs to be done.
Yeah.
I think today, we're left trying to put those pieces together. And when we think about how fast information travels today, I mean, I can just reflect on my children for a moment and think about video conferencing with their friends, and we used to have to go visit them in person. Or we would sit on a landline with the long cord to talk to them. But they don't necessarily need to do that with technology. And information travels so quickly. But when we talk about enhanced care management and community supports, these are the very challenges that we have so many different agencies. Sometimes it doesn't lead to an open door for whatever reason. But we do have that responsibility to kind of connect all of the dots throughout the continuum, not just from a healthcare standpoint, but from a social support standpoint. So I think the way the benefit structure is today for behavioral health, for example, health plans were essentially responsible for outpatient behavioral health care, mild to moderate. So there's a lot of coordination that has to occur just with the county. But then what about the additional social supports that are needed? And do we actually have that data today to connect thoughtfully all of those dots throughout that person's holistic care that they need? And the reality is we are taking steps, but it's a work in progress, and it's a challenge for us when we think about where the expectations are and where we are in terms of the reality of the systems that we're working with. So we have a lot of work ahead, humbling work ahead. Policy work, yes. Complex systems to navigate. And we have a responsibility to figure it out, build the roadmap, build the plane in the air, if you will.
Yeah.
So when I think about true population health management, when we get to the point of that kind of a robust data share and that type of engine, then we will truly have interventions that move quickly enough where we can make a difference in time before it's too late. Because our strategy in alignment with the state is prevention. Yeah. And the other thought around population health, I'll give it to Kristen. Very, very much needing to tie in all of the health equity priorities along with that. And we speak very broadly about population health, but health equity is a major component, and connecting those dots, the integration part, we have to leverage the data to be able to act quickly and to be able to do that. Yeah. So when I think about challenges, we certainly don't have any shortage of them, but Kristen, I'll let you go.
Thanks, Les. I was going to add, I think you both have such tremendously important points. We have a scarcity of resources when it comes to those social services supports, those community-based organizations, the new providers that we're bringing into the system. And I think that we all have an obligation, one way or another, to continue to cultivate that, just as we have an obligation to try to support more nurses, more doctors going to medical school, making sure that we are creating a system that can actually support, right, our members. And that's a little bit scary, right? So I was going to ask Kelly, because she's sitting there, what can we do? What helps create or generate interest for someone to become a community health worker? How do we show up and support them in that journey?
So workforce question.
Yeah.
Sure. I mean, I think CHWs they come at the work because they're passionate and they have lived experience that draws them into the work. They, we have almost 60 community health workers at Sacramento Covered. About 35 are in the Calaim space right now. Health plans are asking us every day about our capacity. We had 35% turnover last year during the pandemic. We replaced those positions and had a net gain by the end of the year, but it's tough. It's hard work. We need to up the ante. I'm glad you asked this question because we, in our world, are really trying to create a new definition about what is the living wage for this workforce. Mm-hmm. And you have to pay them well. You have to provide great benefits. You have to provide a balance to the work, live-work balance. You have to provide chair yoga. You have to provide, so we really, I joke, but we really try to create a supportive environment for a workforce that works incredibly hard. I mean, they are tenacious in serving their clients. But I also want to just offer on some of the other opportunities that we were mentioning, because I think there are some. I 5 years ago may not have said, at least with my colleagues, that I found health plans to be particularly collaborative with each other, and I have seen this with all of you, and I hope that is certainly continues. I think there's lots of opportunity for health plans to align much more on their offerings of community supports, on your processes for billing and data collection, and for referrals even, how referrals are handled. And I know I'm probably speaking to the choir. This is not new information, but I think there's already a lot of variation in California alone, and county by county implementation. Yeah. And I'm sure your lives are incredibly challenged by that in implementing Calaim. But if we can remove some of the variation, For providers, it means that that physician can really focus in on the care that their patients need, or that organizations don't have to figure out 5 different invoicing processes, or how to get a community support authorized in real time while a patient's in emergency department and we know they're unsheltered, et cetera. So I would love for us to talk about the opportunities that exist in, and I know it's only March, right? But, we'll give you till
So,
May.
honestly,
You can have till May.
Part of our roadmap is by May, we will, no, not by May, but, it's actually, hope, right? So the nice thing about what's happening right now is there's a lot of discovery around how to do that exactly. And I'll give you a couple of very specific examples. I'll take LA County just as a place to start. In LA County, there are multiple continuums of care. Each continuum of care is connected and does their data work differently, right? But what's happening is we're having discussions with them about how to connect it and then integrate it, potentially with a health information exchange or a community information exchange or a social health information, however you want to characterize it. And the idea is to be able to standardize the information well enough so that it's integrated, and then eventually it flows into the core records or platforms that are being used by community-based organizations or physicians or county agencies, et cetera. And there have been advancements in terms of standardization of data, right? I mean, I think, I use the example of the screening tool to an ICD-10 code. If we could really focus on making sure that that gets systematized, that standardization and the data collection is going to enable all of this work, is going to allow the plans to really streamline and be able to ingest files in a way that is going to allow each provider to have one process for everybody, because it's standard, right? So there's a road ahead, absolutely, but there's a way to get there. We just have to break each of those silos down one at a time, stay the course and work together on it, because one of the things that tends to happen in communities, and I mean with plans, and I'm sure even within organizations, is that everybody has a really good idea to solve a problem, but if we all have really good ideas to solve the same problem, we all solve it differently, then we end up with where we are right now. So again, I think collaboration and kind of coming to the table together. And one of the things that I'll also just share is, Anthem and BlueShield, HealthNet, many of the other health plans, one of the things that we're doing in just about every single county is we now have these Calaim roundtables that we're all coming together at to have these very discussions, right, with the right stakeholders in the community to get at a solution that's not 10 different solutions, but something that we could all rally around, right? So I do think that there's hope there. But it really is, it's not May. I was just kidding, so don't hold me to that, but it will come.
Okay, June.
June. Maybe by June. Right, so I mean, the purpose of all of this is to improve health. Not just to improve healthcare, but to improve health, population health, data, talked about that. There will be quality measures. There will be measures. How will we know that this is successful? Are you going to be able to measure what's happening when it's even hard to get a billing from a community health worker and what they're doing? How is that going to work?
I think yet another aspirational goal when we think about how do we measure all of this work?
Yeah.
How do you turn the community health worker visit into an encounter that ultimately lands at the state and then gets incorporated into quality performance?
Yeah.
I think we're working to figure those very things out. And I think...
But isn't reimbursement even going to be dependent on this in some way?
That's where the state's headed, absolutely.
Yeah.
So there will be a quality factor built into the rates. The state's talking about doing that effective calendar year 23. Yeah. And so within the scope of Calaim, we have the challenge of non-traditional services. and turning that into an encounter and then measuring the outcomes as part of the fabric of what Calaim is asking us to do. So these are the very things that we're trying to figure out within complex organizations, highly technical organizations that are really being flexible and listening. And I think the idea of the local level discussions on how to simplify things as much as we can, we definitely have every intention of doing so. But we are really trying to roll up the sleeves to understand how do you measure outcomes, from a quality perspective. Because today, we're still training on things like how to bill. How do you get paid? How do we reimburse for the services that are being rendered? So I think that's a major milestone for us to get to the point where we can take it all the way through such that the state can actually thoughtfully measure all of the outcomes on the work that's being
Kristen, it looked like you were going to add something.
Yeah, I was going to say, I think the state always, right, they have to have a way to measure. So we have quality measures, we have the equity components, and those are things that are extremely critical. It's probably going to take, at least 3 years for us to see what happened this year and if we're moving the needle on quality and equity. And I think the bigger challenge is how we know it in real time. And I think a piece of that comes with listening, and I think a piece of that also comes with how we respond to what we hear. So when I'm at a member advisory committee and the members are saying, this just doesn't work for us, right? How quickly can we as an organization pivot and not do that thing, which, by the way, could impact how you're measured. Because if you change what you're doing, change how you're measured. And I think that, as Les and Martha both said, we're listening, we're working, and we're trying different things. I think we have to make it safe to iterate. I think we have to make it safe for folks to try something that fails and for all of us to say, wow, that was a really bad idea. Nice try, but didn't work. And I'm not sure that we're there yet, right? Because everyone's marching towards these very specific goals. And I'd say probably, hopefully long after I retire, if we've done Calaim right, and if we've really lifted the health of the under-resourced populations and the communities that they live in, then we won't see things like a 15-year age gap in longevity, right? So folks that live in Oakland are most likely going to live 15 years less than someone who lives in the Oakland Hills, right? That to me is the true measure, and we have a long way to go to that.
Yeah, we are just about out of time, and I'm just going to give you, I wish we had time to, get questions from the audience. I'm just going to have to ask you to come up and ask your questions individually, but any last thing that you would want to add on Calaim? Kelly, I'll just start with you and we'll go down. Any last thought you would have?
Well, it's a tremendous opportunity for really our beneficiaries, and if we do our jobs right, we will really continue to dismantle systems that weren't necessarily set up to be simple and straightforward, and this gets us a little further down that road.
Yeah. Martha, what would you?
I think I would echo what Kelly said and just add that this is a really good opportunity to create alignment and a common language with a lot of stakeholders that do a lot of really phenomenal work to support these underserved communities. And if we center our focus on the member, on the individual, on that patient, on that client, and align, we're going to do much better together than we have been in the past. So I think it's just a significant and phenomenal opportunity to do that.
Yeah, very good. Les?
I would reflect that Calaim is a transformation, and I think that it truly is an honor to be able to be part of that movement and to be really at the forefront of making these things happen operationally. I'm humbled by all of the expectations and the outcomes that we're striving towards, but just really honored to be part of the process and to be working really at the local level with organizations like Sacramento Covered and who make this happen. We do it together. I think we're pulling all of our resources to the best of our ability. I think it will take time.
Yeah.
But really it is an honor to be part of this.
Yeah. Last word.
All right. It's hard work, collaborate, speak up. right? I think there's too many folks that are silent. Set a bigger table. Invite more from the community, invite more from your members. Really listen, ingest, and really respond to what folks share and say. This is a hugely important thing that we're all doing together, and we all have every opportunity to kind of change how communities in California live. And I think that that is a gift. I'm humbled to have the opportunity to be of service, and I look forward to working with all of you.
It is so important. The potential is so great in making a difference in the lives of, right now, 15 million Californians who have Medi-Cal as their health coverage. So this is so important. You're really making a difference. Thank you for what you do, and thank you for this great discussion today.